Good evening to everyone. Good afternoon and good evening to everyone. Welcome to week 4. And today we will be learning and discussing about communication skills and breaking bad news. Communication skills is the cornerstone in palliative care. To someone who is battling a terminal illness and to his or her family, it makes so much of difference by what is being told to them, how it is being told, and also how we as professionals are able to listen to them. So, to learn more about it, for today's session, we will have two presentations, a didactic lecture and a case presentation. And for the lecture, we have Dr. Savita Butola, who has kindly made herself available. Give me a second. Who has made herself available to replace Smriti Rana, as Smriti had another important task to commit to. So thank you so much, Dr. Savita. Dr. Savita is a commandant and a chief medical officer at the Border Security Force, Panisagar, Tripura. She did her MBBS from the Government Medical College, Amritsar, and she underwent MSc in palliative medicine at Cardiff University in Wales in the United Kingdom, and also did a fellowship in palliative medicine. Dr. Savita is an honorary senior tutor at Cardiff University and an honorary secretary of Indian Association of Palliative Care. She is a national faculty of Indian Association of Palliative Care, Asia Pacific Hospice and Palliative Care Network, and she's a founding member of e-Hospice in India. Dr. Savita has launched the first online bereavement support website in India. Dr. Savita has 10 journal publications, and her area of interests are advocacy and development of palliative care in armed forces. She has received numerous awards for her pioneering work in palliative care. This is so inspiring, Savita, and we would like to welcome you to the session. And with the presentation, following the presentation, we will open for question answer session. And I would really like to encourage our participants to make the best out of it, because we know communication, as I have emphasized, communication is so important in palliative care. But at the same time, we here, as we just start palliative care, we struggle with, how to declare a bad news and how to talk to the patient. So I would really expect the participants to make use of our very experienced resource person here. And following the discussion, then I will do a case presentation. But for now, over to you, Savita. Thank you.
Thank you so much, Tara, and good afternoon, good evening, everybody. I must say it is such a pleasure for me to be here in the teaching program for Bhutan, because Bhutan has always been on my dream list of places to see and meet and just to be there. And I've never had a chance till now. So this is my first chance, and I'm absolutely delighted, even if it is to replace Smriti. But it's my pleasure to be here. So without wasting much time, I'll quickly go on to the slides, and then we'll have more time for discussion in the end. As Tara said, this is a very important topic, communication skills. And before, I got my training, I always thought that it is something people are born with. And it's only now that I realize that it is something we can learn and we can improve with time. So I will go on to the slides and just tell me, Tara, if you can see them clearly and you can hear me clearly as well. Is it okay?
Yes, we can see
All
and
right. So
hear you
thank you.
clearly, Savita. Yes.
So we will be talking about what all is important, what is communication, why it is important in healthcare, what are the types, what are the barriers, why we cannot do it better as we are younger, and then we learn better with time. What are the skills needed, especially for palliative care, and what are the special types of communication that are required when we deal with terminal patients? So we are all aware that communication is an act by which we share information with others, and it's a mutual process. It is not a one-way process. It's not like one person is talking and the other person is listening. It's also about listening, understanding, actually hearing what the other person is saying, expressing your views, understanding things, and being able to pass on that information in a manner which is clear and which the other person is able to understand. So, in the olden times, it was said that patients have to be protected and they don't have to be told everything. It is not good for them. In the 50s and 60s, physicians they were taught that protection of patients is important. But over a period of time, it has been realized that, especially in regard to autonomy of the patients, it's very important for patients to know and understand what is happening to them. And as I just mentioned, that some people are born with better communication skills, but then there's something that we can learn. It's a skill. And like all skills, it can be learned. But what is required is that it has to be done, it has to be practiced. And with that practice, there has to be constructive feedback on one's communication skills. We learn by observing other people's behaviors, and most of the communication we learn as healthcare professionals is how we see our seniors behaving with the patients or the families. But then, if we do it properly, if we have seen people do communication workshops, or if we have seen them in real life doing communicating well with patients, it's a skill that we can pick up. But then we need good feedback, and we need to have rehearsals and somebody to tell us where we went wrong, what could we do better. And it's also very important to remember that communication can be both verbal and non-verbal. And non-verbal, which comes across with our body language, our tone of voice, is so much more important because it's the majority of our communication as human beings is non-verbal. The actual words that we use comprise only 7% of our communication. And in palliative care, it's said that people may forget what you said, but they don't forget how you make them feel. So it's very important. The content is important, but the tone and language and the way we say something is more important. It has more of an impact. So the dignity, the respect, and the caring empathy, it comes across when you talk to somebody. It's important for us, not only with our patients and families, but also when we are talking to our colleagues, our staff, the administration that we are dealing with. Also, when we have to appear before a court to give evidence, to report our research findings, when we are talking to the media or the public or the policymakers. So, communication skills come in everywhere. And it's especially important for patients because when somebody is sick, they are more sensitive. And good communication skills can result in so much better compliance, but also less medical legal problems, less ethical problems when dealing with patients. And you need special skills when dealing with different groups of people. So, for children, for the elderly, and where culturally it is appropriate for males and females to be dealt in different ways when dealing with different social ethnic groups or when dealing with people with learning disabilities, then we need special skills and we need uh, maybe special training to deal with them. And good communication skills help us to build rapport and trust with our patients, increases their satisfaction, and it's a huge factor for joint decision making. Unless somebody understands, they are not able to make informed decisions. It reduces uncertainty for the patients and families through their increased understanding of the illness and the plan of management. And obviously, it results in better compliance of treatment also. But what happens is why we are not able to do it well many times is because we are trained to focus mostly on physical symptoms. When I was a student, uh, maybe 40 years ago, nobody taught me how to talk to the patient. And what we usually saw was that when there was a death, uh, the senior consultants wouldn't come. And it was the interns and the house masters who were house doctors were sent out to give the information. And at 21, 22, 23 years of age, you're not trained to do. You don't know what to say. So it leaves the doctors feeling unsatisfied and it leaves the families feeling dissatisfied as well. So we are not taught. We were not taught in the early days to communicate properly, but it used to be thought of as something, which is beyond our professional work, is mostly physical symptom control. And it used to result in doctors feeling unable to handle the emotional burden that came with the suffering. And then you think of a counselor or a psychologist to handle all the psychosocial stuff. Also, language can be a barrier. Then we often have very little time in the middle of our OPDs with so many patients, especially in developing countries where the number of healthcare workers compared to the patients is very little. And there is a huge number of patients in the hospital. Then doctors or healthcare workers often find themselves thinking that good communication skills would require a lot of time, but a lot of data and lot of research goes to show that this is not so. Patients don't want too much of our time, they just want proper information to be conveyed, and it doesn't really take too much of time, and that's what a team is for. So the barriers, as I was saying, include not only the personal attitudes but language. When we are dealing with patients coming from different parts of our country or from different parts of the world, language becomes a challenge sometimes. Then uh, the healthcare workers may be tired, they may be hungry, they may be emotionally overwrought themselves. And sometimes the team members are not on the same frequency, they may not know, the information between the team may not be shared to the extent that they can properly communicate issues to the patients' families. So, effective communication requires planning, and the whole team needs to be on the same chapter. And it requires, as I said, the helical model. One person is giving information, the other person is getting influenced and sending more information back. So it goes to a different level each time. It's very important when we are communicating to be able to show empathy in our body language, and also to learn how to handle emotional outbursts. It is not about just giving information, it is also about handling the emotional impact of that information on the patient. So, how much information is to be given? Like Tara said in the introduction, how much to tell, how to tell, what to tell, and how to listen. These are the important things. We always have to find out first what is the patient's level of education and understanding. What is their language? How much they can understand? What is their cognitive perception at that point of time? So, interaction is important. Coming down to the patient's level of understanding is important. Using simple language is important. And involving them in decision making is very important. So, when we are talking about communication, a few things that we need to start with is that we should not assume. It's always better to clarify things. Don't assume anything when we are talking with patients. And uh, in the early days, especially for youngsters, I would like to say that don't get emotionally involved, in the sense that don't take things personally. Sometimes the patients are very annoyed, sometimes they may be angry. And healthcare workers are the face of the organization. They are the face of the system. They are the people who come in contact directly with the patient. And sometimes the patient is upset and he'll take out his anger on the person who is nearest, which may be the doctor or the nurse. So, first thing we need to learn is not to take it personally. He's not angry with you, he's angry with his illness, he's angry with what is happening to him, he's angry with his helplessness, and you just happen to be there. So it's very important not to take it personally. And then also not to criticize colleagues, not to make careless remarks about whatever has happened previously. Sometimes, I remember a patient we had referred who was given paracetamol for dengue, and that's the only treatment we normally have to give, paracetamol and IV fluids. And the liver enzymes were raised. So whoever the doctor was in Delhi took a look at his documents and said, "Oh, why have they given you paracetamol? Your liver enzymes have become raised." And now the patient and family were so concerned because they think it's because of the paracetamol. So, so very simple, careless remarks sometimes can create that distrust for other healthcare professionals. Please, even if there is something that has not gone right, it is unethical to criticize colleagues in front of the patient. Then don't give false reassuring comments. So you may give reassurance in the sense that we'll try our best, but don't say you will become okay when the patient is not going to become okay. So, this is something that we learn with practice. This is not something that I can teach in 3 slides or 4 slides, but over a period of time, when we learn communication skills practically, then this is something we learn how to handle. The patient is asking you, am I going to get better? What is going to happen? Will I be okay? But how to actually handle those questions without giving false reassurance is the skill that we need to know. So, what needs to be done is to learn how to balance hope and truth. We have to tell them the truth in bits and pieces, in small bits of information that they can digest at one time. It may require a number of sittings, and you don't have to take away hope. Sometimes we do not tell the patient thinking that patients are not going to be able to handle it, and we are scared of taking away hope from them. But there is a lot of research, there is a lot of evidence which shows that patients want to know. They want to know how to handle the time that is left. And we can do it in a manner which is honest and which is sensitive. So they need, this is something that we need to remember. And this is something I have learned from my mentor that I always like to, teach further, that patients need honest information and appropriate hope. So that information which we are giving, it requires honesty and truth and sensitivity, everything, but it has to be appropriate to their situation. Then active listening is another skill that we need to learn, how to listen. Actually listen when we are just not, listen from one ear and let it out at the other. It's called whole body listening or active listening. So when we have to listen to somebody, get some privacy, sit down with them, make time for them, get some privacy. Then very importantly these days, switch off your mobile. And if you're expecting an important call, please give your mobile or your pager to somebody else in the team who can take it for you when you are talking to the patient. It may even be helpful to tell the patient that, see, I'm in the round right now. I have 10 patients to see, but I will come back at 2 o'clock and then I will give you 10 minutes and we will sit down and talk. So the patient knows that you have 10 minutes and they all understand you are busy. So they know that you have about 10 or 15 minutes. They will prioritize what they want to ask you, but give them those 10 minutes. Then don't have any interruption. Let no one come into your room, switch off your mobile. And when you are talking, sit down at the patient's level, make eye contact with the patient, and don't twiddle, don't do anything, don't scribble, don't tap your toes when you're talking to the patient. Just give them your full attention for those 10 minutes. Listen to what they are saying and also observe their body language. Ask questions when we are talking. We should ask open-ended questions. Open-ended questions means if you are asking a patient, how are you? So ask, how are you? That means patient can tell you anything. Patient can talk about his fever. He can tell you about his headache. He can tell you that he did not sleep well last night or he's very worried. His son is not well. But if you ask, how is your fever? That's a closed-ended question. Are you feeling okay? That is only a yes or no answer. Is your pain okay? So that means he can only tell you about your pain, about his pain. So ask open-ended questions and allow the patient to talk. We should be talking only 20 to 30% of the time, and we should be listening to our patients and families for 70 to 80% of the time. They should do most of the talking and we should do most of the listening. Whereas practically it is the other way around. Also, do not interrupt. Allow them to finish. And learning to remain silent and tolerating silence is a skill that we need to learn. We get very uncomfortable when patients are silent. Supposing you have told somebody about their diagnosis of a neonatal death. Okay, supposing you've done an ultrasound, there's an ultrasound, and you see that the heartbeat is not there. And you've told the parents, and they are suddenly quiet, and you don't know what to tell. So you quickly want to say, no, 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 it happens to most of the, 25% of pregnancies end up with abortions or stillbirths. And next time you'll be fine. It is very important to try another time. Just take 2 months, then try and again. They're not focused. They're not listening to what you have said. So respect that silence. Learn to be silent. It's okay. You just don't have to say anything. Just sit quietly with them. That is another skill. Communication means listening and remaining silent also. Because when they are silent, please remember, this is a very beautiful line I have read in Robert Twycross's book, that when the patient is silent, you think he is silent, but there is a lot of noise going on in his mind. So he's somewhere else. He's thinking there's something going on. Just respect that and give him that time. And also the importance of just nodding, saying, allowing them to go on. And if it is appropriate, in some cultures, it may not be appropriate to touch, but if it is appropriate, a gentle touch on the shoulder or on the hand, just holding the patient's hand, can be very supportive and helpful. And patients will not be hurt if you joke with them appropriately. So, if it is appropriate, a gentle humor lightens up the mood. It can help the patient feel normal and better. Um, these are again some things that we do when we learn practical skills about how to repeat patient's phrases or to reflect. Like the patient says, I did not sleep well at night. I was very worried. So you pick up on that and say, oh, you were worried. Why were you worried? What were you worried about? So these are things, repetition, reflection, paraphrasing, or summarizing. These are things we learn practically. I've just put them here on the slide to help you when you go back and read the PPTs. It will help you remember. But as we were discussing, there were a few specific skills that we need in palliative care and that we will talk about now. These are among the most important is how to give negative news to a person, how to break bad news. It is something we will be doing a lot of time. And we do it in our clinics also, apart from palliative care, also we are doing it. We don't think of it, but any information which seriously affects a person's view of his future is bad news. So, for a child who is planning to go on a holiday and suddenly the mother falls sick, the child cannot go for the holiday, is breaking bad news. And for a sports person to have an ACL tear in his knee and be told that he will not be able to play tennis in future is also breaking bad news. So these things are relevant to whatever branch we are working in. It is not about just palliative care, but yes, the skills are more important when we are dealing with terminal people. And if the patient is young and the doctor or healthcare worker is also young and inexperienced, then it is more stressful for both. So again, it is said that break bad news well and you will always be remembered. Break bad news badly and you will never be forgotten. So why are we not able to do it without experiencing sadness and anxiety is that sometimes the messenger is confused with the news in the patient's mind and also in our own minds. We do not want to bear the burden of being messengers of bad news. So it causes anxiety for us also when we have to break bad news. And the we don't want to tell bad news to anybody. It's called the mum effect. And we are also afraid of being negatively evaluated, of being thought of as failures. And also, as I said earlier, we are not trained in communication. Um, we want to give them information without taking away hope. And we are slightly uncomfortable with dealing with, sadness, crying, emotions we are not taught how to handle. So all of these act as barriers in breaking bad news. But it's important to remember that it is the patient's right, both ethically and legally, to know the truth so that they can take informed decisions. And it's a legal requirement in many parts of the world. But the thing is that for years and years, we have not been telling patients the truth. And suddenly, we cannot change that whole culture in one go. So, we have to learn and we have to do it gradually. We have to teach our workers and staff slowly that this is important and how to actually do it. So, patients who are told the truth and who know they are empowered, they feel more understanding about their situation, they are more satisfied, they don't feel hopeless, and there is more chance of psychological adjustment, and they can decide whatever they want to do with the time that is left for them. There are different protocols. These are different guidelines with different mnemonics on how to break bad news properly. One of the simple ones that we like in our teaching is that something called spikes, SPIKES. It's a simple 6 step protocol. And this was given by Robert Buckman, who was an oncologist and specialized in communication. The first step is S, spikes. The first thing is S, which means the setting. Set up the interview properly. Whenever you have to tell the patient something important, which is bad news, then make sure that you have the privacy. You have finished whatever you have to do. You're not angry, you're not hungry, you're not tired, and you do not have to go to the washroom. Sometimes, this is very important. It may make you laugh, but in a busy OPD, when you have 200 patients to see and you're very hungry, you want to go to the washroom, then you don't have time and the energy to tell things properly. Please eat something, drink water, sit down, give your phone to somebody else, as I said, go to the washroom, and then sit down with the patient. Sit at the patient's level. Sometimes never break bad news in the corridor. If the patient is admitted, you just may find a stool to sit down, or you may sit at the patient's bed on a chair on the side of the bed. Draw the curtain around you so that there is at least some privacy, and then talk to the patient, look at the patient eye to eye. Ask them if they want somebody else is important to them. They may want their wife or husband or son or brother or somebody to be there with them. Allow them to be part of the conversation. First thing is to ask the perceptions. This is step 2, SP. P is for perception. So find out what they know about the illness. Ask them, what have you been told earlier? Have you seen your reports? What do you think? And these days, with the availability of internet, the first thing patients do when they get their reports is go to the internet and Google it. And we think they don't know, but they have already read what is the prognosis, what is the diagnosis, what is the average lifespan. They know everything. They just want you to confirm. So find out what they know, what they understand. Then 3 is invitation. Obtain the invitation. Ask them, would you want me to tell you your report? How much do you want to know? So sometimes, if it is an 80-year-old grandfather, he will say, oh, I have lived my life. I don't want to know what is in my report. You just tell my son what to do. My son is handling my treatment. You just tell him what to do. I am not interested in the details. But a young 30-year-old male who has 2 children to look after and who has a young wife who is not employed, he needs to know. So he will tell you, please tell me everything. I need to know my reports in detail. So just ask the patient how much information they would want, or they want the details, or they just want the brief outline of the report and the further treatment. Whether just you have to ask them what they want. Then the next step is K, knowledge, giving them knowledge. Always start with a warning shot. Don't give bad news abruptly. Say, I'm sorry, the report is not as good as I had thought it would be. And I'm sorry, I have to tell you that. So the patient is mentally already ready that there is going to be something which is not good. So start with a small warning shot. Then tell them in simple language. Do not use medical words. Do not use technical jargon. Don't be very blunt. And bluntness can leave the patients very isolated and angry. And they tend to blame the healthcare workers in case the treatment doesn't work out. So be polite, sit down, give them the news in small pieces, see what they have understood. Don't give all the information in one go. They may not be able to understand it. Do not use words that convey hopelessness. And please understand that patients may be too emotionally overwhelmed to understand even simple information. So check what they have understood. So you have told them the report, just ask, what have you understood? They may require to be told repeatedly. Sometimes you may have to tell them 3 times, 4 times, and they get so overwhelmed, they're not registering what you have said. So just understand that it is very, they get overwhelmed with that information and their processor is not working. So just as your computer sometimes gets overloaded, similarly, human minds get overloaded with information and we may have to repeat it again for them to understand. Always check the understanding of the patient. Find out what they understand may be very different from what you meant because of the language or their level of understanding or their emotional turmoil. So please make sure that both of you are on the same page. He's understanding or she is understanding what you actually meant to say. Also, look at the patient, observe the patient. Six is empathy and emotions. So, uh, observe the patient and see, are they silent? Are they sad? Are they angry and hostile? Are they having disbelief, shock? And to yourself, name that emotion. Try to understand and name that emotion to yourself so you are able to handle it better. If the patient is silent, ask them, what are you thinking? What's going on in your mind right now? Would you like to tell me what you are thinking? And understand why he's thinking that. Stay silent for a while after you have told the news. Um, Give them some time to process their thoughts and emotions and make some comment to show the patient that you've understood. Something like, I know this can be very difficult to hear. I know this report has been very tough for you. I know you must, I can imagine. Don't say I can understand because patients think nobody can understand. So avoid using the word understand. Say, I can imagine how you must be feeling. This report is difficult to hear. I'm sure this is not what you expected, but I'm sorry. So the next and last step is the sixth step. Spikes S stands for strategy and summary. So when we have told them, when they have let out their emotion, if they have cried, it's okay. You can give them a glass of water. Um, in palliative care consultation rooms, we always advise please keep some water for patients and a box of tissues. That can be very helpful. Offering them water if the patient is tearful or starts crying, giving them a tissue shows that it's okay for you to cry. I accept your emotions. I accept the fact that you are crying. It's okay to be vulnerable. So it gives a message. So do keep water and tissues in your consultation room. And when that is all over, give them time, then ask, would you want me to discuss further treatment with you? Because they have to be emotionally stable enough to understand what you are saying. Otherwise, do it in the next consultation. Um, Ask them, give them some choices, ask them what they would like to do, and just give them more time. So often what happens is we break this news in one consultation and we just generally tell them that this is going to require, say, chemotherapy or surgery or radiation, and we will discuss more when you come back next time. Or you may want to bring somebody along to discuss the treatment and make sure that there is somebody with the patient who can take them home. Sometimes patients come alone to take their reports and they may not be in a condition to drive safely back. So please see that there is somebody with them. Otherwise, make arrangements for them to be escorted safely back home. And generally, there can be another session 3 or 4 days later, 2 days later, to discuss the further strategy for treatment. So that was about breaking of bad news, one important part, and we discussed spikes in regard to that. I will discuss in 2 slides and then I'll stop. Two important uh, parts of communication skills. One is collusion and one is denial. So collusion is when two parties get together and hide information from the third party. So it can be the doctor and the family getting together, or the family telling the doctor, this is the most common scenario, that our patient will not be able to handle this news. My mother will get very sick if you tell her that she has cancer. She will lose all hope. Please don't tell her. And the family and the doctor get together to hide the truth from the patient. But sometimes the collusion can also be between the family and the patient. Like when the patient and the family hide the fact that the patient has a history of drug or alcohol abuse. We had a patient who died of liver failure, a young boy, and the family and patient, none of them told us that he was an IV drug addict. So the treatment might, it was a sudden acute failure, and the patient died within a day and a half. But that was something we came to know later. Then the collusion can also be between the doctor and the patient, where the patient requests, we have many times a serving person who is with us and the family is staying at home. So they say, please don't tell my wife that I have an alcohol addiction problem. Sometimes things may work out in different ways. So the collusion can be between all the three parties. In palliative care, the most common one that we see is where the uh, family does not want to give information to the patient. And it is usually an act of protection, an act of love on their part, because they want to protect their loved one from that pain and hopelessness. And they think that the patient will be too emotionally uh, destroyed to hear that news. So we must respect that concern, and we have to slowly convince them that if we do not tell the patient the truth, which is anyway, as I said, a legal requirement, it erodes the trust that the patient has on the team. So it's important for us to involve the patient in decision making. It is the right of the patient to know and to plan their life, but we respect your choice and we convince the family to let the patient know. We don't break that collusion by, going out and telling the patient everything. And sometimes if you go and tell, the family will take the patient away and take them to another place where they may not get proper treatment. So it's very important to build trust with both family and patient and see that it is they come around to understanding that yes, it's important for the patient to know. So we tell them it's okay, we will not tell everything, but this is why it is important, and we suggest you tell, or you stand by us and help us to involve the patient. So gradually they come around, but generally we need to break it gently, talk to the family a number of times so that they can understand why it is important for patients to know. And another important thing, another important skill that we need to handle, denial. Denial is a protective coping mechanism where the patients don't want to accept the truth. You may tell them everything, but they will say, no, 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 I feel okay. Nothing is wrong. I'm fine. And this is a coping mechanism. It is a protective mechanism where the mind tries to protect the person from the inevitable, from facing mortality. So it's not important to break it always, unless and until it is interfering with treatment. If the patient is following the treatment, it's okay. We can, I'm sorry, there was a call in between. Sorry for the interruption. So the patients, if they are following the treatment properly and they are agreeing to the planned treatment realistically, it's all right. We may address it gradually. But denial just generally gives them that psychological um, coping which is required. And as I said in the beginning, it's important when we are talking about communication to learn about handling of emotions of the patient. So it's very important to keep calm when we are talking to patients, even if they are angry. And remember to respond. Think and respond. Don't react emotionally to circumstances. Supposing the patient, we have just given him the news of his biopsy, and patient is saying, your hospital is rotten. I do not believe anything. Your pathologists don't know. And I'm sure they've not made the correct diagnosis. So I want to go to another hospital and get an opinion. So you may react in two ways. You may react by saying that, oh, you are doubting our hospital. So you go wherever you want. Who called you to this hospital? Or you may say, it's okay. I understand that this has been a shock for you, but please sit down, have some water, and we'll talk it over. Right? So, still, if you want a second opinion, you're most welcome. But listen to his concern. So, just handling that anger or handling that outburst, patients may start crying. The handling emotions is sometimes the most difficult part of communication. And sometimes they will have genuine problems in the hospital. Sometimes the staff has been rude to them. Sometimes the doorkeeper, the person in the lift, the person who's bringing in the patient from the ambulance, sometimes they can be very rude to the patients. So, being nice and empathetic or being courteous to the patient has to start from the door. It has to start from the security person, from the person who is bringing in the patient in the lift. Because otherwise, bad behavior from our staff can undo everything that we are trying to do empathetically in our clinics. So say, I'm sorry. Listen, if they have a complaint, if they have a genuine problem, listen to them. Say, I'm sorry this has happened to you. We will take care. Don't say it didn't happen, and don't say I apologize, because we don't know what has actually happened. Sometimes patients may interpret things in a different way. Staff may have said something else. Without listening to both parties, don't make a commitment, but you can always say, I'm sorry it happened to you. I'm sorry you feel this way. And this is not apologizing. It's different from offering an apology, being sorry. So just say, I'm sorry this happened, and then go on from there. You will also learn when you're handling communication to learn when patients ask you, how much is the time left? Is there nothing to be done for me? Then find out what they actually mean. Um, they may have something else. Sometimes the patient is saying, how much time do I have left? You'll be in the ward and you'll say, oh, he's asking me how much time he has left in his life. And then you ask him, why are you asking? He says, oh, because I'm planning a vacation with my daughter next month. So when are you discharging me? How much time do I have in the hospital? So he's asking you about his discharge, whereas you are thinking about how much time he's left in his life. So always clarify. And as I said earlier, don't criticize colleagues, because patients understand things in a different way. Always check their understanding of what you have said. And ultimately, communication requires patient practice, good feedback from your colleagues, observing each other. And we must understand that it is not for us to give solutions to the patient's problems in life. It is just for us to facilitate them in finding their own solutions. Patients find their own solutions. We just have to be there for them. And I'll stop. This is the last slide. This God has given us one mouth and two ears, and we need to use them proportionately. So we need to listen more and talk less. That is what good communication is all about. So thank you very much. And I'll stop sharing now and we'll listen to Tara as she talks about her case presentation.
Thank you very much, Dr. Savita. Such a comprehensive presentation, and you've given us the tools to how to really do an effective communication, and it's very helpful. Thank you so much. And before I go to the case presentation, I think we had one person who raised his hand, Karma Tenzin. Maybe if you would like to ask question, please, the floor is yours. As we wait for Karma, there's one question from the audience here. There's Dr. Sonam who says, how to resolve when there is a very emotional response to a news? Do we escape and let the patient blow off some steam and then attend to talk to them at that emotional moment, helping de-escalate? So maybe Savita, if you could help answer that, please.
Ma'am, you are muted, ma'am.
Thank you. Okay, so that was a very valid question. Actually, knowing how to handle the emotions is sometimes the most difficult thing practically. So, Dr. Sonam, what we usually do is first, as I said, identify the emotion. The emotional outburst can be a vast thing. So, patient may be angry, patient may be shocked, patient may be silent, patient may end up crying. So, the best thing is to observe them, see what is happening, let them, but don't leave them and go. Sit with them, identify that emotion. And as I said, if the patient is crying, you can gently pat them, hold the hand if it is appropriate, just let them be, give them some water, ask them, can you tell you, would you want to share what you are thinking? And then they will they will go on from there. But just as I said, learn to be there without saying anything. But yes, if the patient is angry, then listen to them, find out what has happened, and offer them support in the sense that I'm sorry this has happened to you. If they had a bad experience, you can say I'm sorry, and we'll find out more. We'll try to support in whatever way you can. So you're not saying your staff has made a mistake. You're not saying that the report was wrong, but you are offering support. So I'm sorry you are in this situation. I will do my best to help you. And that usually is enough to take care of the emotional outburst. So if somebody else has another experience, or there's something that you would like to add from your experience, I would like to welcome you here.
Yeah, thank you, Savita. Um, yeah, it's often sometimes when you have just declared a news and then the patient becomes emotional and then you just feel so uncomfortable that at times you feel like running away. But I think, as Savita emphasized, I think staying there, no matter how hard it is, being there itself makes so much of difference to the patient that it at times is very difficult, isn't it? It just makes you makes you break down as well. But rather than running away, I think being there with them, uh,
Yes,
trying to control your emotions if possible, uh, actually is helpful for the patient. I'm a very emotional person, and it makes me very, that's the biggest, the hardest thing that I experience. But
I totally
I,
understand. I can
yeah.
understand. I think, as one of my teachers says, that people who work full time in palliative care are worked in a different way. They are wired in a different way. Huh? So that is probably why we are here. And there are two things to think about. I will not say anything, but I just want to give you some food for thought. One is, um, we have to understand our own emotions and be comfortable with our own emotions and with being vulnerable before we accept it in other people. It's okay. It's all right. That's what makes us human. And second thing is that just ask patients what they prefer. Do they prefer a cold, detached doctor who is unfeeling but very efficient? That that sometimes is okay in the operation theater. But when you are dealing with people who are dying, patients don't mind if you shed a tear. Okay. So there is a huge amount of literature also in that. There are reports of interns of postgraduate students crying under the stairwells when patients have died, especially children. So it can be very emotional, especially when you are dealing with dying kids, but it's okay. Patients understand you are also human, and there's no harm in crying with the patient. Absolutely no. It just makes you more human. It's all right. If you shed a tear with your patient, it's okay. But yes, there has to be that line where you do not become so emotionally upset that you are not able to take the treatment decisions properly. If you are getting so involved for whatever reason, or if you know the patient already, or it is somebody already close to you, then it is better to hand over the treatment to somebody else in the team. But yes, crying with the patient doesn't make you less of a doctor or a nurse.
Yeah. Thank you, Savita. I completely agree, and this is very helpful. I'm wondering if Karma is ready. Karma Tenzin, would you like to ask your question, please? Maybe we will let Karma speak after the case presentation with the interest of time. So let me first share my slide and okay. Can you see my slide?
Yes, it is visible.
Okay. Thank you. And so, yeah, actually, one of the doctors was supposed to do a case presentation, but somehow he got caught up with another commitment. And so, uh, as I didn't have much time, I thought I will do one. And this is um, um, actually a case of my own family member. But I thought we will together learn from how we dealt with it, especially with communication, as we, I know we, many things went well, but many things did not go well. And so together we thought we will discuss here and learn from it. So my patient, actually, she was my mother-in-law, and she was 72-year-old and got diagnosed with advanced cancer of pancreas. Just to give a brief background, she was short like me, thinly built, and a very hardworking and independent lady. She had never been to school, but her husband was an ex-health worker. So my father-in-law had worked as a community health worker for many years and was towards his later part of his professional life, he was working as an admin in the Ministry of Health. They had three grown-up children, a son, who is my husband, and two younger sisters. And they had four grandchildren, two from us and two from one of his sisters. My mother-in-law, ever since I knew her, she used to chew tobacco. And I think she did it from a long time ago. And she was an occasional drinker, she used to drink alcohol, people in the village make an excuse that if they are tired, if they have done some work, their excuse is, let me have a cup of, wine or alcohol. Or so she was if there's some celebration, drink a little. So she was an occasional drinker. I will narrate it in a kind of a story. So she was a known case of diabetes and hypertension. I think she was started on diabetic treatment around 2004 or 5. And but it was well maintained. She was on a low dose of anti-diabetic and antihypertensive. And in 2015 and around 2013, she started having this issue with osteoarthritis. And she was referred to India in Durgapur and got a new knee replacement surgery in 2015. And about a year later, until 2022, she was very active. She was very hardworking. She could do everything. And because she and her husband were both doing well, all of her children, we were all abroad. in 2020, one of my husband's sister also decided to go for a study in the US. So all their children were abroad. It was only two of them at home in Bhutan in Thimphu. And so around July 2022, she started experiencing pain, epigastrium, and then loss of appetite. So, because my father-in-law was a health worker, she was immediately taken, because often in our country, in our context, people go very late to the hospital, but I feel she was at least taken to the hospital in time. So at the hospital, she was advised gastroendoscopy, and she was found to have esophageal varices, and binding was done. And following the binding, I think she was advised not to eat solids and to just take liquids for about a week or so. And with that, she lost some weight again. And she was advised a repeat UGIE about 2 months later. And in September 2022, she had another endoscopy and was found to have some more varices, and had undergone some binding again. And so with that, she was again put on liquid diet, and was losing weight, several blood tests was done. She was also done endoscopy. She was also done ultrasound, CT scan, and then we were all throughout in conversation. Even if we were abroad, my father-in-law would send me the reports, and none of the reports indicated anything serious. And we were asking them, should do we need to come, is there anything serious? And both of them said, there's nothing serious, you don't have to come when you are done with your studies, and there's nothing to worry, everything is being done here, doctors are taking care of them, I'm taking care of them. So my father-in-law would also assure us that nothing very serious. So in early November 2022, I was supposed to join my office, and my husband and I came to Bhutan. And when I saw her at the airport, I then and there thought there is something very serious with her, looking at how much weight she has lost. Of course, we used to do video calls and all, but looking at her face to face was really shocking, to be very honest. She has lost about 15 to 20 kilos in 6 months' time. And so she also had started having diarrhea 6 to 7 times a day. There was pain, abdomen on and off, not very severe, but a mild pain on abdomen, and loss of appetite. And so about a week after we came here, we reviewed her with her treating physician. And based on the reports that were available, CT scan, ultrasound, the endoscopy, we were assured that there's nothing very serious and nothing to be really worried about. And for the varices, we were advised to get her reviewed by a hepatologist in India, as we don't have one in the country. And because looking at the way she lost her weight, I was like really concerned if it could be cancer or anything. But I didn't mention it to the doctor. But I asked whether she could be referred, and because the reports did not indicate anything serious, we were advised to take her to get a consultation, and so referral was not really, advised, because in Bhutan, patients are referred on government funds, and the whole cost is borne by the government. And interestingly, the patient actually asked the doctor, "Is it not cancer?" Maybe because she could feel. I think the patients knows the best what is going on in them, and so she did ask the doctor, "Is it not cancer?" And the doctor actually reassured that it is not cancer. You don't worry. It is something to do with your liver. And, if it was cancer, we would not have kept you like this. We would have referred you. We would have already treated you. And so we also became really convinced. We also thought, oh, I think we worried too much. I think there's nothing very serious. So we were like, and end of November, I was supposed to go back to Australia for my graduation, and I had another summit. But my husband was in dilemma whether to go or not to go. He had his work there, but he had his ailing mother here, and he was in dilemma. But his parents wanted him to go because we had our two young children in Australia. And they didn't want them to be on their own when I came back, because I was supposed to come back in December after completing everything and then start working in Bhutan. And so they actually asked my husband to also go back. And I'm dilemma, but we both went back and we kept following up, but she was not doing well. So my husband's sister is also in birth. And so she decided to come and take care. So she came, but the situation was not really good. Then she started, her diarrhea increased. She was completely loss of appetite. She was losing weight. There was increased fatigue. And so we actually thought, take her to Vellore immediately. And I came back to Bhutan on the 22nd of December, and they left on 23rd of December to Vellore. My father-in-law and my sister-in-law escorted them to Vellore. Now, at CMC Vellore in India, thorough investigations, including, CT, MRI, ultrasound, endoscopy, and colonoscopy, and thorough blood workup, found that within 5 to 6 days, a diagnosis was confirmed. And the diagnosis was a fourth stage of cancer pancreas with metastasis to liver and intestines. And my father-in-law and his daughter, my sister-in-law, were explained that it looks bad, nothing, like there's no treatment possible except palliative care. Now, I was in Australia studying PhD in palliative care, and my family members, including my sister-in-law, well, knew quite a lot about palliative care. We would discuss about it, we would talk about what it is. And also because my sister-in-law worked in a hospital in Australia. So she's not a nurse, but she's a support worker there, and she knew about it. So, there was such a shock in the family. I was equally shocked as well because it was overwhelming to know that there's nothing much to be done. And initially, I think we all denied the truth for a while. I too denied it, but we had to come to terms with it. And now my father-in-law was there, my sister-in-law was there, but my husband was still in Perth, and one of his sister was in the US. We had to tell them. My father-in-law initially told not to tell my husband. He's the eldest, but the most weakest in the family. And so it was so difficult to let him know the reality. My father-in-law said not to tell him, but I was insisting to my father-in-law that we must somehow tell him before it is too late, because when there's nothing much to be done, we may not have much time. And so I insisted, and gradually on a video call with my daughter taking care of my husband in Perth, my father-in-law in Vellore, we had to let my husband know that this is the reality. And so he decided to fly to Vellore. My sister-in-law in the US also was told she's much stronger with all these spiritual, practices that she does. And although it was very hard, so she too flew to Vellore. Until then, the patient did not exactly know the diagnosis, but the doctors were telling the family members to take her back home, that you do not have much time. And interestingly, I used to call my mother-in-law and talk to her. And you know what she told me was, I don't know, initially the doctors would come to the room, explain everything, that they will do ultrasound today, CT scan tomorrow. But these days lately, they take, Papa and my sister outside, and they talk to them. They don't talk to me. And that way she became increasingly curious. Actually, she was like more restless. She would listen from the door what they are communicating outside the door. So and on the other hand, we were discussing, especially my sister-in-law who escorted her to Vellore, two of us, and with the father-in-law, we were discussing whether to tell her or not. And we thought, because the whole family members themselves are not in terms, when they're not in terms of the truth. So we thought, let's not declare while in India. Bring her home, and maybe we will declare her properly at home. So we decided that. And she was sent home with oral chemo. I even talked to the oncologist there and wanted to really know how would the oral chemo benefit her, because I was emphasizing that we failed in making a timely diagnosis and we don't want to fail in giving her, a treatment. Uh, um, if chemo was not going to be helpful, because I was concerned of the side effects, and it did actually. She was advised 6 weeks of oral chemo, but with the second cycle, she started having severe side effects. She was also sent other medications for her diabetes, for her hypertension. She was also sent a pancreatin and many other medications. And my husband and my sister-in-law, while in Australia, had one of their friends' mother who had lung cancer and was put on this DXN capsules and tea. I don't know how popular it is, but I'm reading it. It is quite popular even in India. DXN, tea, DXN. It's nothing but a dietary supplement which contains mushrooms, Ganoderma, that I read in online. And so they had a belief that it may do a miracle. It is quite expensive, and they bought it for about a month or two, and so they came back. They arrived to Bhutan on the 13th of January 2023. Now, what were some of the concerns? Well, there were a lot of concerns actually. All of us had to come to terms with the reality. I was mainly concerned of how much time do we have, and how to make the best of her remaining time. I actually expected at least 6 months, and so, having studied palliative care, the best approach would be to make the best of the remaining days. And to do that, it was important to communicate with my husband, her eldest and the only son, communicate with my father in law, you know, communicate with my sister in law, and also to communicate with my children, young children who were overseas, who grew up with my in laws. They were very close to them, and to communicate with the patient. Well, at times I found my patient was much more, receptive or stronger than the other members in the family. And she would often say, "Oh, I'll be all right. You all don't worry. I'll take this medications. I'll do this. I'll do that," because she was equally or even more worried of her children, no matter how grown up they were. And so, as we were communicating, on the day they arrived, because my mother-in-law was already in doubt, she asked us, what is my problem? Is it cancer? And then we didn't want to tell lies. We didn't want to give her wrong information. And so we said, it says it is cancer, but you got lots of medications, and we will do everything, to get it treated. Initially, we said that, and gradually we were actually, as Savita mentioned, we were giving her in doses at a regular interval as things progressed. And what I remembered as we were taking care of her was the importance of declaring that truth, that bitter truth, at a right time, at a right place or a right environment, and by the right person. Well, I was a health worker. I'm a health worker, and I knew about the illness. But at times I thought I may not be the right person, but, my husband, her son. And so I would prepare my husband. I would say, look, we may not have much time, and so it's important that because my mother-in-law is a very, she often reminded us, please don't tell lies, don't hide anything from me. I need to make decisions. I need to, sort out my whatever things I need to. So that gave us confidence actually, and so we gradually prepared her for what was coming. And at the same time, with medications, we also conducted all the necessary cultural rituals like the pujas. We made offerings as much as we could. And we also took her to visit some temples because she was critical. A main issue was diarrhea. We couldn't take her much further, but we took her to nearby temples. And as Savita mentioned, we involved her in making decisions. I would ask her, what would be best and whom should we call to do these rituals, and what do you feel? So she would advise us. She would suggest, let's do that, let's do that. And so it was much more easier for us. And also, many of our relatives from across the country came to visit when they knew she wasn't well. So, in summary, she was a 72-year-old, very hardworking and independent lady who still wanted to do so much in life. Towards the end, she told us, "What's happening to me? Am I dying? I still have lots of things to do." So she still had so much to, she still wished to do so much. And our emphasis was that do everything possible to help her and all of us have a better quality of life. And their communication was vital. We ensured that there was adequate symptom management. We emphasized that there is, as much as possible, psychological and spiritual needs being addressed. And as she, went downhill, we particularly, I really prepared my husband, my father-in-law, and my sister. One of my sister-in-law had to go back to the US for her studies. She did have vacation, but she didn't have much time. So three of us, my husband's father, my husband, and his sister. So four of us were taking care of her at the end of life, and I was literally trying my best to help them communicate with her till the very end. Express their gratitude, make sure, let her know that we are all doing our best and things like that. And so, what we, in that 2 months after diagnosis, she died on 9th of March 2023. And within that 2 months, we could have done much more, but uh, the little that we could do could help her sort out her unfinished business. Like when my husband told her that, we are doing everything possible, but the disease is quite advanced. And, if there's anything we could do, if there's anything you would wish to, she once mentioned that at the first instance, she told, well, I may not die so early, I will at least survive for 5 years, she would say. But and then 2 weeks or so later, she would say, well, one of my wishes was to distribute these whatever little possessions, family possessions among the children, And also towards the very end, I think once she started having severe pain, then she really knew she was actually going to go. And then she told her daughter, I was not there, but her daughter, to give her whatever little possessions she had, the jewelries and all, distribute it, give this to this, give this to this, you take this, you give this to your sister, So at least we feel, had it not been palliative care, uh, uh, it could have been completely different. We would not have told her. We would have all been focusing on physical symptoms, and we ourselves would have been so distressed. So the discussion point here, I thought, was the patient's right to know, as emphasized by Savita. I think we often assume that patients will go into depression, they will lose hope, and so we feel not to tell, but it's their right to know. And also, who should break the bad news? I really felt it should be the right person telling her, the person the patient trusts the most. And so, and also when and how it should be done. And then making sure, once the diagnosis has been told, once the prognosis has been told, making sure that there is adequate support to both the patient and the family, because everyone is equally affected. And so making sure that the support is there for the family and the patient. Yeah. Thank you. That's from me, and I'll stop sharing the slides and invite questions and points for discussion. And maybe would Savita have any comments or questions to start with, and then we will go with other participants' questions. Thank you.
Thank you, Tara. That was very comprehensive, and you elucidated all the relevant points nicely. Uh, Thank you so much. I think we just have enough time to take questions if anybody has.
Okay, so I would like to invite for questions, please. Is Karma ready to ask question, or he had his hand raised? Karma Tenzin. Okay, anyone who has question or any comments, or maybe share your experience as to how you struggle communicating with the patients. Was there someone who came up with the question? Okay. Okay, there's one
Maybe I
question.
have a
Okay. Yeah.
yeah. In this case, you had two situations you had to handle. One was your relatives who, where you had to somehow weigh when to inform them and when to actually inform the patients. How much time did you give in between, and what was the reason for that?
Thank you. Thank you very much. Actually, what I initially thought was the family members need to know the truth first. And so then we all are on the same page. But also because although we were few numbers in the family, each one had our own unique characters, unique strengths and weaknesses. So as I was saying, my husband was the weakest, and the two younger sisters had to actually help him come to terms with it, and I was there, surrounding them. So once we knew, and she was brought back home, we were by then all family members, including my children overseas, knew what was the truth. And so it was a matter of about 2 3 days, because by then they were traveling back to Bhutan, and we actually thought we will take some time. But she was curious, the same day she asked us, and when she asked us, we didn't want to delay it anymore, and so we told her on that same day. So I think it was a matter of 1 to 2 days or so. Yeah, just to confirm her. She actually knew something was very serious, but she just wanted to get it validated from us. And so, yeah, it was like, thank you.
Patients often observe things and they can make out more things from the way their bodies are behaving, the way the pain is
Correct.
increasing, they're not getting better in spite of treatment. And as I told you, they will sometimes know because we think patients are not educated. One patient asked me, "I have cancer, no?" So I said, "What makes you ask that?" Because they've referred me to the Tata Cancer Memorial Hospital. As simple as that. Huh? Then there was this
Exactly.
child who was 14 years old, and he says, I know I have lymphoma. So again, who told you? Says nothing. The nurse left the file on my bed, and I read it was called lymphoma, and I then Googled and found out everything about it.
Um,
Right? And another child with rhabdomyosarcoma, an 8-year-old girl, she is telling me, ma'am, no, she used to call me auntie. Auntie, I'm not going to live very long now. So I said, Beta, what makes you think that? And like your mother-in-law said, no, she observed the same thing. Earlier when the doctor and nurses used to come for the rounds, they used to talk to me and they used to talk in front of me. Now they take my mother and not my mother, but they take my father and my uncle to the next room
exactly.
and they talk there and they don't tell me anything. And I often hear my mother and my aunt crying at night. My mother is not sleeping, she cries at night, so I know that I'm not getting better and I'm going to die soon. So children especially observe so many things from our body language and they can infer so many things even if we don't tell them.
Exactly. Yeah.
And
Yeah.
that was about patients. And personally, I came to palliative care because my father had CA prostate and he had a spinal cord compression before he was diagnosed. And I was told, I was very young at that time, just out of college, and I was told that, oh, you can go back to your work. He will have a year to live. And I had not even unpacked my suitcases the next day when he passed away. So I still feel cheated of that time, which I could have spent. two
Exactly.
weeks, 3 weeks with him. So it's very
Exactly.
important for us to know what is actually happening.
Exactly. Exactly. Oh, yeah. Thank you, Savita. I think we have hand raised. Tundril, do you want to come forward, please?
Hello, I've met a few patients where they had cancer, where we recently diagnosed them, but their family members are very unwilling to disclose the information to the patient. And I've also witnessed where it's been pretty chronic, and then patients are very debilitated, but they still don't know their diagnosis, but the family is still disclosing them. So, in this situation, as healthcare practitioners, what should we do? It's because sometimes we want to let the patient know. Is it for the right of the patient to know, or is it regarding the family members' decision, or that I found it a bit complicated. So if you could share that info, thank you.
Yeah.
Anna, will you take that? Or should I
I
answer
thought
it?
I will invite you.
Okay. So the thing is, it's never simple. It's never simple, and each case is different. So, see, what we talk about in theory on the slides looks very easy, but it's not so easy in real life. And each patient, each family, each culture is different. Autonomy of the individual is given so much importance in the West and legally, but in collectivistic societies like ours in Southeast Asia, it is not easy for us to not listen to the family. So it's always better to find a way where everybody comes to a consensus. And again, it is also said that it is the right of the patient to know, but it is not the duty of the patient. So if the patient doesn't want to know much, or if they want only a bit of the information, it is okay. And again, there was this question here, a similar question here that what about finance? In our society, sometimes, what happens is the person who is paying is the decision maker, which may be very unfortunate and it sounds really harsh, but then that's how it is. And as far as gender is concerned, that is another thing. Uh, Patients, the elder patients or the women often delegate their decision making authority to their husband or the eldest son or the somebody who is paying. So they will say, okay, let my husband decide. The women are often not the decision makers. So it is something that will come with time. But yes, if the patient wants to know, the family doesn't want them to know, then we have to spend time with the family and slowly bring them around, try to bring them around to the fact that the patient wants to know, he needs to know why it is important for him to know. But then, as I said, you also have to see where the patient is. A 30-year-old patient is at a different point in life. He needs to settle legal financial matters, has to settle the children before he dies, as compared to an 85-year-old grandfather who, it doesn't matter if he doesn't know. If he doesn't want to know, the family doesn't want him to know, it's okay. But then people at an older age are so much more accepting of the fact. We think our parents will get hurt if they, come to know, but they already have made peace with the fact that they are going. Somebody who is 70, 75, 80 years old, somewhere at the back of their mind, they know that slowly, the time is coming. And they are wiser than us. They have more experience in life. They have gone through more losses. Education is one thing, and wisdom and experience is another thing. So uneducated people coming from the villages may not be very educated, but they have seen so much of life. And life and death is so much more a part of their daily routine than it is in the city. So as you said, it's not easy. It's never easy. Comes with practice. That's all I could say.
Yeah. Yeah. Thank you, Savita. And also, just to add, I also felt, as Savita mentioned, it's so much to do with culture and one's spirituality. And I think we in Bhutan are predominantly a Buddhist country. We pride ourselves, often as a Buddhist, uh, our, I think one of the principles of Buddhism is impermanence in life. And When we are well, we reflect on impermanence, but when we are unwell and when we have a terminal illness, we want to we want to forget impermanence. So bringing in
गएछ एक just बटबट थियो कि त्यो चाहिँ गएछ अहिले
fellows. Okay. So what I was saying was, sometimes bringing in spiritual people, if the family wants, if the patient, tell them, and if they talk, some patients really reflect on that impermanence of life, and then all this birth, old age, sickness, and death and dying, and so taken care of their symptoms, taken care of their other issues, and then bringing in a spiritual leader sometimes helps them to prepare. There's never a perfect timing, never a perfect preparation, but it helps. And that's how it also helped us to prepare. It also helps the patient to prepare. But assuming, I think Savita made it very clear that never assume. We assume that, oh, she will get hopeless. She will not eat then. She will then go into depression. And so don't tell her. I think it's completely sometimes knowing whether the person wants to know, and then talking to the family members. Sometimes the family members also assume, and then they don't want the person to know. But once we talk and discuss and find out, they also agree, and then they also reflect, and they also start opening up. So if there are any more questions, please. Because one of the things was, I think I shared on the very first day, first session, was also because family members who had not shared the prognosis or the diagnosis with the person who was dying, sometimes at one point later in life actually regrets for not having told the person. I have a neighbor who lost one of their loved one to pancreatic cancer. And when we lost our mother-in-law, my mother-in-law, the neighbor came to visit us, and he was sharing his story. His patient wanted to know, but they could never tell her. And he asked me, did we tell her? So I was saying, yes, we tried telling her. It wasn't easy though, but we tried telling her. And then once she knew, things became easier actually. We could involve her, we could take her suggestions, we could discuss with together. And he felt that he could have done that as well. He could have told her, and he felt bad that he could not tell her. So at least it was the truth. It was a bitter truth, but it was the truth, and we did what the patient wanted to. And so I think that I feel is better than not having told her and regret later on when nothing can be done.
And they say it takes an emotional toll on everybody in the family to constantly be acting like everything is okay. So they have to keep up that appearance all the time and act out that part. So once truth is out there, then everybody is more comfortable. So, but I think videos, you can go to the internet, and I'm sure Pallium will send you some more resources where you can see videos of interviews with patients, or how breaking bad news can be done, how collusion can be broken. So you will be able to do it slowly with role plays and with watching other people do it. It will take time, but everybody learns gradually.
Thank you. Any last questions? Looks like there are no more questions, but I think today was the first session that we finished on time, maybe because we had one didactic session and a case presentation. But thank you so much, Dr. Savita. I always felt communication is one of the most important, because even to ask the patient and the family to take opioids, so much of communication makes a difference. So much of the way we communicate with the patient and the family makes a difference. And ultimately helping the patient to come to a reality that he or she is dying, and the family to let them know that their loved one will not be alive for a long time, is so much to do with communication. And you have given us such a comprehensive presentation with how to do it, what could happen, what could be the barriers. And so I think we learned a lot. This is one of its first kind of education session for our Bhutanese healthcare professionals in the country. And I'm so grateful that you made it very clear to us. Thank you very much. And thank you to all the participants as well. I would like to hand it over to Sangeet. Um, Thank you.
But before I say thanks to all the participants and to Pallium for inviting me here, and as Paulo Coelho says, nothing happens by chance. So today Smriti couldn't come and I came, and your doctor couldn't come and you came. So both of us are here together by chance.
Thank you, ma'am.
It was
Thank you
meant
very
to
much
be.
for coming.
I agree. Yeah, I agree.
Thank
Thank
you very
you.
much. It was very informative sessions today we have. Thank you, Tara, for bringing your case presentation. So we have a detailed discussion. Thank you everyone for joining. Thank you everyone for participating and making it an interactive section. Thank you. We will meet in the next session. Bye.
Thank you. Bye.
Thank you. Bye bye.